Thank you, and welcome everyone to the webinar, Locating and Engaging Hard-to-Reach Members During COVID-19, a panel discussion. My name is Laurel Risch, and I'm with the Lewin Group. Today's session will include presentations, followed by a panel discussion and live question and answer with the presenters. This session will be recorded, and we will be posting a video recording along with today's slides at www.resourcesforintegratedcare.com. The audio for this presentation automatically streams through your computer. Make sure that your computer is connected to reliable internet and that the speakers are turned up. Phone lines are also available. You can access that telephone number by clicking on the black phone icon that's at the bottom of your screen. This webinar is supported through the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. MMCO is helping beneficiaries duly eligible for Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in both programs. To learn more about current efforts and resources, please visit our website or follow us on Twitter for more detail at @integrate_care. At this time, I'd like to introduce our moderator for today. Renee Marcus-Hoden is the Deputy Director of Community Catalyst Center for Consumer Engagement and Health Innovation. For the past 20 years, Renee has worked to bring the consumer perspective to the forefront of health and health innovation. Renee?
Thank you, Laurel. And I just want to add my welcome and my gratitude for everyone who was able to take time out of this busy season to join us. I'm so pleased to be with you all today for this webinar on engaging hard-to-reach members during COVID-19. As Laurel mentioned, I'm the Deputy Director of the Center for Consumer Engagement and Health Innovation at Community Catalyst, a national healthcare advocacy organization working to elevate the voice of consumers in health and healthcare. And I've had the pleasure of working with the Lewin Group and the Medicare and Medicaid Coordination Office over the last several years on a variety of webinars related to the topic of today's webinar. So this year, I also had the extreme pleasure of facilitating the Integrated Care Community of Practice, a learning community of health plans, each of which serve low-income older adults and people with disabilities, some of whom we might classify. And I want to point out that classification is for a wide variety of reasons, as so to speak, hard to reach. The community of practice participants were plan staff that hold responsibility for developing, overseeing, and implementing strategies for engaging members in care. And we met 6 times over 8 months to share challenges and promising practices. Our community of practice launched in March, about a year after the pandemic began, and just as vaccines were becoming more widely available. This topic was very much in the forefront of participants' minds and daily experience. In today's webinar, we'll share lessons that emerged from that community of practice. So I'll first take a few moments to introduce today's speakers, and offer a roadmap for our time together. We'll start out with brief overviews from each of our 3 organizational representatives. First, we'll hear from Lauren Easton, the Vice President for Integrative Program Development and Clinical Innovation at the Commonwealth Care Alliance in Massachusetts, or CCA. As a behavioral health leader for the plan, Lauren has been largely responsible for developing CCA's behavioral health integration across its care models. She's also been responsible for creating a responsive network and for creating many innovative programs, some of which she'll be talking about today. Lauren served as a guest faculty member for the community of practice earlier this year. Next, we'll hear from Tasha Asifo from Community Health Plan of Washington. Tasha is the manager of community programs at the plan, working to advance health equity by addressing social determinants of health. Tasha leads a direct services team working to support members managing chronic conditions and addressing member social needs. Tasha was a member of this year's community of practice. Next, we'll hear from Jennifer Klopstein from Viva Health in Alabama. Jen is a Special Needs Plan, or SNP, administrator at the plan. Jen provides support for Viva staff working with their D-SNP enrollees and monitoring the activities associated with their D-SNP as outlined by their model of care. Like Tasha, Jen was a member of this year's community of practice. I know that you're all going to enjoy hearing from this incredible lineup of speakers. Lauren, Tasha, and Jen, thanks so much for being with us today. Why don't we go to the next slide? So our next slide is our learning objectives for today's session. So by the end of today's webinar, participants should be able to identify strategies for locating hard-to-reach members, including through the deployment of community health workers and through partnerships with community-based organizations. They should also be able to identify strategies for addressing unmet social needs and building trust through tangible supports for members, for developing information system approaches to contacting hard-to-reach members, for reaching members with limited English proficiency, those experiencing homelessness, or those with serious mental illness, and finally, for providing COVID-19 vaccine outreach and education to hard-to-reach members. And if we go to the next slide, we'll look at the agenda for today's program. So as we start, as we typically do, that is, we'll start with some polls to get a sense of who's in the audience. Then we'll get brief overviews from each of our three organizational representatives. We'll hear from Lauren first, followed by Tasha, and then Jen. Each of them will share with us information about their plans, some basic information about their models of care, as well as some of the challenges their plans face in engaging hard-to-reach dually eligible members. The bulk of our time today, however, will be spent in a conversation I'll have the privilege of moderating among Lauren, Tasha, and Jen, in which we'll pick up where their presentations left off, the strategies their plans employed to address the challenges of locating and engaging their harder-to-reach members during the pandemic. Following that discussion, we'll leave plenty of time for Q&A from all of you. And finally, as always, we ask that you all stay on to complete a brief evaluation of the webinar. So if we go to the next slide, we'll start with our polls to understand who's with us today. So first poll is, which of the following best describes your professional area? Are you in a health plan? Are you with customer service, pharmacy, medicine, nursing, physician assistants, or other types of provider, social work, advocacy, health plan case manager or care coordinator, health plan administration or management, or something that's not listed? If you can choose one that best describes, we will see where most of our audience is from. Okay, looks like the responses are coming in, and we're seeing that the nearly half of our participants are from health plans, almost 10% from social work. Let's see, a few from the advocacy world, a large number, almost 30%, from health plan case managers or care coordinators, and again, approaching 10% on health plan administration or management. Terrific. Why don't we go to the next poll, please? And next, let's talk about the setting that you work in. Is it the ambulatory care setting, home care agencies, long-term care facilities, academic or research environment, a consumer organization, a community-based organization, a health plan, or something that's not listed there? You can make a selection of the one that best describes the setting in which you work. We'll just give it a couple more seconds. Okay, why don't we go to the poll results on the next slide, and we'll see where folks are from. Okay, well, it's very clear here. We have nearly 80% that are from a health plan, followed by the next nearest, which is almost 10% from community-based organizations, a good number that we didn't quite capture, and then a scattering across the rest of the settings. Okay, thanks for filling out our polls. We're really pleased to see that we have a diverse set of professional areas, if not from a diverse set of settings, that is. But I think that the folks on the call today will have a lot to gather from our speakers. And speaking of that, let's go to our next slide, and I will turn things over to our first speaker, Lauren Easton from the Commonwealth Care Alliance. Lauren, you can take it away.
Thank you so much, Renee. Good afternoon, everybody. I'm so pleased to be here with you this afternoon. My name is Lauren Easton. I'm the Vice President of Integrative Program Development and Clinical Innovation. I have been fortunate to work for Commonwealth Care Alliance for about 18 years now. Next slide, please. A little bit about Commonwealth Care Alliance. We are an integrated care system serving members who are dual eligible for Medicaid and Medicare that are truly the most vulnerable members across the state of Massachusetts. We are in a unique position as both a payer and provider, and our roots started as a provider in primary care. We have 4 primary care sites across the state of Massachusetts. We had 2 crisis stabilization units serving 26 beds, and we have a unique model of what used to be called our CCA complex transitional care, but now our hospital to home program, which I'll talk a little bit about later in the presentation. Next slide, please. A little bit about our plan demographics. As I mentioned, we really do serve the most vulnerable populations across the state of Massachusetts. We currently have 2 products in the state of Massachusetts. We have a senior care options product serving members that are 65 and older who are dually eligible. And we have a OneCare product, which are serving dually eligible members under the age of 65. As you can see, over 74% of our folks have a behavioral health disability or physical disability. We have 70% of our folks in the OneCare have a severe SPMI, a severe mental illness, and 30% documented have a substance use disorder. We do think that's a higher number, however, this is documented. In our senior care option program, about 60% of our folks have a physical or behavioral health disability, and many of these are nursing home certifiable, but are living in the community, getting services through our model of care. Next slide, please. So a little bit about our model of care. Again, being in a unique position as both a payer and provider, all of our members have access to a community-based interprofessional team that consists of APCs, PAs, behavioral health clinicians, health outreach workers that are similar to community health workers, and OT and PT. But not only do they have access to a clinical team in the community, we really have a coordinated effort to collaborate with all services along the continuum of care, so including primary care, inpatient services, outpatient services, emergency departments. Our hospital to home program is we have co-located doctors and health outreach workers directly in the emergency departments, partnering with physicians in the emergency department. In addition, every single member has a care partner. So when they enroll with us, they are assigned a care partner and have access to that care partner on a daily basis. Next slide, please. So again, as I mentioned, a little bit about our model. We really try to meet our members where they're at. So much of our work is done in the community. So we may see people in their homes, we may see people in shelters at their day program, we may see people who are homeless or marginally housed at a Dunkin' Donuts or even under a bridge. We have, again, as I mentioned, seamless integration of care and coordination through our care partnership. We are consistently collaborating with, again, transitions of care, human service providers, community-based organizations to ensure that our members have a seamless continuity of care. We really focus on trusting relationships. Many of our members have had difficulty getting access to care in systems or have a lot of gaps in care in the systems and have a distrust of the services that they often don't have access to. So we really focus on that individualized long-term relationship and building trust with our members. Ultimately, through our clinical models, our facilities, and our collaboration with community partners, we really see a decrease in overall utilization and member satisfaction and better outcomes. Next slide, please. So in terms of our health risk assessment, every single member that enrolls with us has a face-to-face assessment within 90 days. However, through the pandemic and due to COVID, some of these assessments are now done over the phone, and these are done by a registered nurse. The assessment really helps drive the care plan. In the care plan, we focus on an individualized care plan driven by our members. But the initial assessment, which is inclusive of medical assessment, a social determinant assessment, as well as a behavioral assessment, really drives that care plan and gives us an understanding of the resources that are necessary for each member. As I mentioned, we have a hospital-to-home program. So when our members are utilizing the emergency department, we are notified, and our doctors partner with doctors at the emergency department to make a shared decision as to the best level of care placement, whether that is inpatient or if they are able to transition back into the community with intensive clinical service, we are able to offer that through our interprofessional teams. In addition, our health outreach workers are there to support the doctors in doing an SDOH assessment to determine levels of resources that are necessary in the community as well. Next slide, please. So some of the challenges that we occurred, again, many of our members are very challenging to locate and have difficulty building relationships. As I mentioned, they have had a distrust of the system and often can be stigmatized when seeking services. So it's really important for us to be able to build those longitudinal relationships. And it was challenging to think about how we were going to do this when we weren't able to see people in person initially. Many of our members are changing addresses, phone numbers. We don't have accurate demographic information. So we really have to work with locating when they're going to the pharmacy or transportation to figure out what their address is, phone number is. In addition, many of our members have Department of Mental Health Services coming in or a personal care attendant coming in or VNA services coming in. So they've got a lot of people coming into their homes, and sometimes it's difficult to be thinking about one more person involved in their care. Also, our members have often are seeking, because of their barriers to care, they're seeking their care through the emergency department instead of their primary care providers or human service providers. So if they're going all over the state at various hospitals, we only have access to immediate notification at 4 hospitals in the state of Massachusetts. It can be difficult to track these members and engage them on a consistent basis. Next slide, please. And with that, I'm going to turn it over to Tasha. Thank you very much.
Thank you, Lauren. Hello, everyone. My name is Tasha Asafa. I'm the Manager of Community Programs at Community Health Plan of Washington. Happy to be here with you all today. Next slide, please. Community Health Plan of Washington is a local not-for-profit organization providing access to quality Medicaid and Medicare coverage for Washington's underserved residents in their own communities. We have nearly 30 years of experience and long-established roots in health equity. We have over 270,000 members covered under our Apple Health Integrated Managed Care, which is our Medicaid plan, our Medicare Advantage plans, which includes our dually eligible beneficiaries, and our Behavioral Health Services Only plan. We were founded by and are still governed by community health centers, which in turn are governed by community members. The health of our members is our primary concern, and we are committed to improving their health and well-being. The foundation of our integrated health services approach is locally delivered whole person care, which recognizes the broad needs of our members and provides support in the communities in which they live. CHPW's aim is to advance health equity and improve the lives of the people we serve by addressing the barriers to health and well-being. Our members come first. Next slide, please. Community Health Plan of Washington serves over 7,000 dually eligible special needs plan beneficiaries. 48% of them identify as non-white, 59% identify as female, 34% live with a serious mental illness, and the average age is 67 years old. Our programs are designed to proactively identify and address behavioral, social, and medical needs of our members and to support the whole person's needs. We make decisions that are motivated by the best interests of our members, providers, and communities within the state of Washington. Next slide, please. We provide comprehensive support for our most vulnerable members Our model of care provides holistic support for SNF members and brings clinical case managers and providers into collaboration. This collaborative support is comprised of special health services, case management, and care coordination. All duly eligible members are enrolled in special needs plan case management and are assigned to a case manager during enrollment. The health risk assessment is completed within the first 90 days and annually thereafter. Case managers will also complete a new health risk assessment for members with a change in health status. The health risk assessment assesses for social determinants of health needs, mental health, emotional health, health habits, and health improvement. Community Health Plan of Washington also utilizes community health workers to locate hard-to-reach members with behavioral health diagnoses. Our community health workers complete the health risk assessment and then complete the warm transfer to Community Health Plan of Washington case managers. Next slide, please. So some of the challenges that we experienced engaging hard-to-reach members throughout the COVID-19 pandemic. So members have limited access to communication, including the internet and phone, so limited access to technology and communication. So our members have limited phone minutes. Many of them utilize phone service with a phone benefit where they don't have unlimited amount of time to talk and communicate with us and service providers, in addition to limited access to the internet. So during the pandemic, free internet access and Wi-Fi sites shut down, so there was limited access there for folks to be able to use the internet. Members have a lack of trust in the healthcare system. So Lauren shared this as well in her information presenting. Some of our members have not had the greatest experience with the healthcare system in general, so there is a lack of trust. Some of what we experienced is just a general lack of information available at the onset of the pandemic presented some challenges for engagement. One of the other challenges we had, members were preferring to have case managers and others on our team assist with more immediate needs while not wanting to answer or engage in the health risk assessment or health-specific questions. So we had members solely focused on what can you do to help me with, you know, a doctor's appointment that I might need to change? How can you help me get connected to food or some other services? Not interested in really talking about some of those other health needs. And lastly, limited face-to-face contact. So again, with shutdown and things being closed and social distancing, not being able to get out into the community to find and engage hard-to-reach members was a barrier for us. Thank you, and I will pass it over to Jen.
Thank you, Tasha, and good morning, everyone. My name is Jen, and as mentioned previously, I'm the Special Needs Plan Administrator for Viva Health. So Viva Health was founded in 1995, and we are a health insurance company as well as an affiliate of the University of Alabama, Birmingham. We serve over 100,000 residents in the state of Alabama for their health insurance needs in a variety of ways, including a commercial line, our Medicare line, which includes our D-SNP with about 19,300 members, and our Medicaid line, which is a management service for the Alabama Coordinated Health Network. Our D-SNP plan is voluntary, and it covers about 30 counties across Alabama currently. In 2022, we expect 2 more counties to come on board, making it 32. Recently, we achieved the 5-star rating, so we're very excited about what's coming in 2022 and the ways that we can impact our members. Just some demographics about our population within the state of Alabama. The majority of our members in the D-SNP plan, which would be about 2/3, are female, and the remaining third is male. A little over half of our members identify as Black, just under half identify as white, and then the remainders are just under 1% of the population. When it comes to education of our members, we do also pay attention to that due to health literacy concerns. 40% of our members have a high school diploma or GED. 25% have some high school education but did not graduate, and 16% of our members have an 8th grade education or less. About 1/3 of our members are under the age of 59, so our D-SNP plan does have some youth to it. About the same amount is in that median range, which is 60 to 69 years, and then just a little bit over 1/3 are 70 years or older. Another aspect to consider for Alabama is 59% of Alabamians living in urban areas, and contrasted with the 41% in rural areas, which will impact some of the things we speak about in a bit. Next slide, please. Our model of care really places emphasis on providing opportunities for our members to become successful self-advocates, as well as independent navigators of their health. We strive to make communication with our members as effective and efficient as possible. Our HRAs, for example, are an area we attempt to leverage every opportunity of interaction to complete this within our SNP. This is a pivotal point to our care plans as well as our ICTs. So we really, really want to make sure we focus on the HRA completion. However, there are hard-to-reach members, and no matter how hard we try, sometimes we don't reach those members. So what we have done to be creative is creating a hard-to-reach button that is spanned across all of our EHR, and it is something that we can hover over so every member of our team can see it. This would be something if another department is interacting with the member, that they would know that this is something we need to collect, as it is so essential to our care. When it comes to collecting our HRAs, it's not something that we're doing on every single interaction, but it is something that we want to make sure we're collecting at least every 6 months, or if it's coming due with that annual. If we have a member that's experiencing transitions, we want to make sure that we're using a tool that can effectively assess for any changes. And then, of course, the initial HRA, which might lead into that hard-to-reach button, is completed telephonically with our outreach team. Our HRAs, like everyone else's, I'm sure, cover the 5 domains, but we also included a free text question that we can collect information or bring attention to any needs beyond those primary or core questions, including opportunities to request intensive care management by our member. Intensive care management is completed by our V-Care team, which consists of nurses as well as social workers, and it is there for eligible members needing assistance with a variety of things, such as transitional care, medical education or needs, and behavioral health. At this time, our intensive care management, or V-Care team, is considered a voluntary program, so it's not something that someone is automatically enrolled in. A member may be referred to this program by a variety of ways. They may self-refer, they may be referred by a PCP, a specialist, or some other provider. Our predictive analytics that we utilize may also indicate there could be a need for management, or a member may be experiencing a transition. And of course, as I mentioned, the member must accept these services. It is not mandatory. Viva Health really focuses on equity and partnering with local groups working in our underserved areas to improve access to care. We like to find out where our members of need are and focus our needs throughout the state of Alabama where our concentrations are. Next slide, please. So some challenges that we have come across and are very similar to the other 2 presenters would be streamlining our communication to members. This has been a focus because the COVID-19 pandemic really transitioned a lot of our care, which used to be face-to-face and very community-based, to a more telephonic style. And we really want to work on streamlining it to prevent any phone fatigue. Another challenge that we have faced is getting updated demographic information. Sometimes state data may be outdated or it may have duplicate information. So we really want to focus on trying to find as much new and usable information with our SNP members, and this can be very difficult. Reaching out to members who are admitted in inpatient behavioral health settings can also be a challenge, and this is understandable because of the heightened protection for this population's privacy. But we work on relationships within the neighboring hospitals to ensure that we can try to reach out to our members. And the last challenge to mention would be those chronic hard-to-reach members. They are not only hard to reach as the initial engagement, but they can be very, very difficult if we were to engage with them and maintain that engagement. So keeping our members communicating with us can also be a challenge. And now back to Renee for the next topic.
Thanks so much, Jen, and thanks, Lauren and Tasha, and of course you, Jen, too, for providing us with some background about your plans, your models of care, and of course the challenges of locating and engaging harder to reach members over the last, I think we're at 21 months now, since the pandemic really began here in the United States. So those presentations really provide us with a perfect launch pad for our next section, in which we're going to just dig a little bit deeper on the issues that you flagged in your presentation, but really focus most of our energies and our time on the strategies that each of your plans has used to find and engage these members since March of 2020. So if it's okay, we'll just jump right into the conversation. And I guess I'll start with where Jen left off and where each of you left off in your presentation, which is around the common challenges. And it seemed that looking across each of your slides there, that locating hard-to-reach members was one of the most common challenges. So I'm hoping that each of you can elaborate on how this challenge was exacerbated by the pandemic. And Tasha, if I can start with you.
Yes, thank you, Renee. Most of us know and experience how quickly many of us became reliant on technology to deliver services or to connect with our own loved ones after the pandemic started. The COVID-19 pandemic exacerbated challenges for us in locating hard-to-reach members, especially those with limited access to phone or technology. It became even more difficult to engage these members when face-to-face interactions were limited, and members could not be reached reliably via phone or technology. Prior to the pandemic, one of the ways we could connect with members would be at events, for example, recreational time at shelters, time that's open for like meals or games. Events were canceled and continue to have barriers to entry and limitations due to the ongoing pandemic. So this presented a barrier for engagement and continues to present a barrier to engagement for us.
Sounds very familiar. Jen, why don't I take it over to you, and then we'll have Lauren follow.
So as previously mentioned, the pandemic really changed up a lot of things for these vulnerable members, and we had to heavily rely on telephonic outreach. Prior to the pandemic, we're very face-to-face and in the community with our members, so this did dampen some of our efforts, and we had to be much more creative on how we would reach out and much more efficient with how we reach out. We also have several members that are in rural areas, and they may rely on like a landline telephone. I know it seems like a thing of the past, but there are several that do have that, and that would limit our ability to contact them if they weren't at home or where that number is. Members with cell phones may have limited coverage as well because it is rural and very mountainy in some areas of Alabama, or just very sparse. There may be a limitation on those phones because of the minutes, so that can put constraints on not only meeting with us, but the member also having to watch those minutes to work with their providers telephonically. And then another thing would be just the general lack of consistent access to the internet for a lot of our members.
Oh, thanks, Jen. I really appreciate you bringing in the rural aspect of this. Lauren, why don't I turn it over to you to talk about some of the unique challenges that CCA faced.
Thank you, Renee. Very similar to Jen and Tasha, but in addition to technology challenges, our typical outreach efforts, as I mentioned earlier, were difficult to impossible due to COVID-19 safety protocols. Typically, we conduct many of our visits for our member population in their homes or residential programs or day facilities, shelters, or elsewhere, basically mostly in the community. With many of these locations shut down or unavailable during the pandemic, locating hard-to-reach members became even more difficult. In addition, many interventions with our members occur face-to-face within the emergency department, so we had to shift away from engagement in that setting as well. So for many of our members who we had established trusting relationships, we had unpredicted success with transitioning to virtual care. CCA pivoted very quickly at the beginning of the pandemic into a virtual care modality. But for folks with whom we hadn't had an established relation or trusting relationship resulting from at least one face-to-face engagement, it was very hard to connect with them. Like Jen and Tasha, many of our members do not have access to technology or phones.
Thanks, Lauren. You actually gave us the perfect segue to talking about strategies that your plans use to overcome these pandemic-induced challenges. So if we can start talking about those strategies with you, Jen, and then we'll go to Lauren and then Tasha.
Sure. So we focused on a telephonic outreach that was for our entire population, just to complete a wellness check. These calls were framed more of a conversation. We didn't really want it to feel like we were diagnosing someone or just focusing on the medical. We wanted to know how our members were handling the stress and really put out a human interaction so that our members understand we care about them, but also that there are other people that can help them in the pandemic. We would provide resources during that interaction if it were to come up in the conversation, and this could be things like transportation or food insecurity, as well as just general COVID education. Like I mentioned previously, we have that hard-to-reach button. This was created slightly before the pandemic, but it really seemed to come in handy with that so that we could make sure we know who our hard-to-reach members are, and if that member were to call in for something, we know why they're calling in. We know who also needs to talk to them, and we get to them as quickly as possible so that we can take care of everything within that call. This button is built in, like I mentioned, to every aspect of our EHR. So if someone is lacking their HRA, we can hover over that and we see that they need to be transferred to our HRA outreach route. If they need to update their demographic information, discuss medication adherence with our pharmacy, or complete things like update their address so we know that their eligibility is still true, we can do that all within that hover and try to address everything as efficiently as possible. The hard-to-reach button has been very impactful for that streamlining, as well as communicating throughout our organization because we are spread out across the entire state of Alabama. When it comes to adding and removing that button, we really try to get that taken care of within 24 hours. That way we can quickly see if the member were to call back that they need to complete something like an HRA, or prevent an unnecessary transfer for that member having to sit, like if we had already completed it but it wasn't taken off. This has allowed us that effective communication and also allowed us to demonstrate how much we care for and respect our members' time.
Wow, it sounds like it was really useful both for your internal purposes, but more importantly for the member experience with the plan. So thanks for sharing more about that. I was really intrigued. Lauren, why don't we turn to you for some of the strategies that CCA used to overcome the challenges you described earlier.
Thank you. Although we were trying to reach out to every single member in the organization, we prioritized outreach to our members at higher risk of adverse outcomes associated with COVID-19 infection or those with greater risk due to psychiatric or medical complexity. As we assessed higher risk members, we had a team in the field with appropriate PPE that spanned the state that could conduct a home visit for those with whom we couldn't connect with telephonically or were at higher risk and necessitated a home visit. Because of the barriers of going into the community, staff who would have typically been in the field could now spend more time calling members or providing support to our care partners. We did many wellness checks to assess for needs related to social determinants of health, including food access, housing, transportation needs, and pharmacy needs.
Oh, thanks. It sounds like the wellness checks, both telephonic and in person, for both you and for Jen, were really very helpful. Why don't we turn it to you, Tasha?
Thank you, Renee. Similar to Lauren and Jen, at the onset of the pandemic, we reached out to every single one of our members to ask them about their needs. Again, similarities there. It was very conversational, really asking them, what is it that you need from us? What would be the most helpful? We would address those needs by leveraging our community health workers and case management teams, providing resource education and connecting members to services. One of the ways that we worked to mitigate the challenges with technology was to create a shortened assessment. As I mentioned previously, many of our members have limited phone minutes, if they do have cell phones, and we wanted to ensure that we were addressing, again, the members' immediate needs what they valued, what they felt was most important at the time, and ensure that they knew how to get in contact with us for additional support. Prior to the pandemic, we had two teams. One was primarily in the community, and the other was primarily engaging in telephone-based outreach efforts. As the pandemic evolved, our community-based team experienced pauses and restarts with face-to-face interaction. At times, the community-based team had to rely more on telephonic-based outreach efforts.
Thanks, Tasha. Okay, I want to switch up to another topic, which has been sort of alluded to in both your presentations, but also in this conversation so far. So can you describe, or can each of you discuss how you partnered with community providers to meet the needs, including some of the unmet social needs that many of you described before of hard-to-reach members during the pandemic? And for this one, why don't we start with Lauren?
Thanks, Renee. CCA is overseeing, in collaboration with the state, a statewide isolation and recovery site for all individuals who met financial and clinical eligibility requirements and tested positive for COVID-19. These individuals were either homeless or marginally housed and could not return to shelters or other facilities for care. Individuals are provided with a hotel room and 3 meals per day, clinical oversight, behavioral health services, and linkages to additional services as needed, including recovery coaches or detox. As a result, we could flag CCA members if we identified they needed additional support after discharge. We also are integrated with many hospitals, so we identified members going into the emergency departments, and we could help successfully transition them out of the hospital and back home and provide them with necessary services within the community. We have partnerships with what CCA defines as health homes, not the typical definition of health home, but human service organizations and community health centers across the state, and partnered with shelters to identify our hard-to-reach members. We work with these organizations outside of the pandemic, and our collaborations were heightened during the pandemic.
Thanks, Lauren. Excuse me. I know that during the community of practice, we heard kind of live about the isolation and recovery site. So it's great to be able to share that with this audience as well. Why don't we turn to Tasha next and then to Jen after that to talk about partnerships with community providers.
Thank you, Renee. So members that had unmet social needs in the context of housing or other needs due to limited financial resources prior to the COVID-19 pandemic, those needs were exacerbated by the health crisis. The pandemic resulted in many changes for those in the workforce, and what we saw was an increase in individuals looking to access social services. As a result of shutdowns and an increase in folks seeking to access services, we began to experience delays in responses from social programs. With the initial stay-at-home or shelter-in-place orders in the state of Washington, we saw a lot of need related to food security. Individuals were concerned about going out in public or they didn't have transportation. We leveraged our team to pick up and drop off groceries. One of the other things that we did, we also expanded our partnership with a local organization to deliver prepared meals to members who were quarantined due to a presumed or confirmed case of COVID-19 and were experiencing food insecurity. We also received daily notifications of our members that tested positive for COVID, and we outreached to them to notify them and coordinate the food benefit. We also partnered with a community-based organization that primarily serves refugee and immigrant women. In collaboration with this community-based organization, we put on a series of webinars in 5 different languages, Arabic, Dari, French, Swahili, and Amharic, for these women that focused on a healthy lifestyle. COVID-19 was an area of discussion in the webinars, but we also focused on overall health, including mental health, substance use, sleep hygiene, exercise, diet, and what you can discuss with your doctor. We partnered with county health departments to have our case managers assigned to isolation and quarantine sites so that we could connect with members who did not have a home in which to quarantine. Case managers would access our dashboard for information on our members at these sites, and then they would connect with the on-site coordinators to get members engaged in case management services.
Tasha, thanks. Really wanted to underscore your partnership with the community-based organization that serves the African refugee and immigrant population. So that's really a terrific partnership and certainly a trusted organization. Thanks for that. So Jen, why don't I turn to you next?
Well, food insecurity proved to be a big issue for our members, and connecting them with agencies within the community was really essential to addressing this. For example, if we were to determine there was a donated food site where we had resources available in an area and we knew there was a high concentration of members, our care managers, if they were working with the member, especially during the intensive care management, could share this information about those organizations and how or where or when they could get that resource. They could also share this information during their weekly care manager meetings within the team so that other resources that might be available for another person's patient or member could be utilized. We really made sure that we were mindful of local churches as resources, the Salvation Army. There's also the Community Food Bank of Central Alabama, and then other shelters that might have had food available that were donated. So we spent a lot of time leveraging those relationships to make sure that the information could get disseminated to our members. Social media can also and was also a very helpful resource for our team in gathering information quickly and a good way to confirm availability and then communicate that to the members. Prior to the pandemic, we had also had staff situated in the hospitals throughout Alabama as kind of an early warning system for our transition. So what we did throughout the pandemic was assure the hospitals were still conducting our outreach and we're still providing care management to the members. Just noted that it may not be the traditional face-to-face like we would do, but rather telephonic. We are still working with those hospitals to make sure we can reintroduce our staff within their COVID protocols. Another thing that was very helpful was an over-the-counter benefit that we had prior to the pandemic, but really seemed to shine during the pandemic. This is a benefit that allowed our members to get things like personal hygiene items such as toothpaste, body wash, masks, mouthwash, and it could be shipped directly to their house so that they would not have to worry about traveling to a pharmacy and potentially being exposed to COVID. We hoped that this benefit would help alleviate some of the members' stress or worry about COVID-19 because they are chronically ill and at high risk.
Thanks so much, Jen, and thanks for ending that on some of the, the items that we don't necessarily think of right away when we think about unmet social needs. I wanted to shift gears a little bit now in our conversation. As I mentioned in the introduction, this community of practice started meeting just when vaccines were becoming more widely available. And so I wanted to have you guys talk about a recurrent topic within the community practice, and that's about, COVID vaccine outreach and engagement. So I'm hoping that each of you, and we'll start with Jen this time, can share some of the strategies that your plans and any of the providers that you work with use to support those COVID-19 vaccination outreach and education processes. So again, we'll start with Jen and then go to Lauren and then Tasha.
What we did is incorporate care plans into our telephonic outreach that would reiterate evidence-based messages from the CDC, somewhere where it was valid information about the pandemic. In the beginning, these goals would focus on hand washing, social distancing, or other guidance provided at that time. And then once the vaccines became available, we would help inform members of good information sources about the vaccine, support the members in things like assisting to schedule their vaccinations. We also focused on hesitance in providing education about the vaccine, and one method was our social media accounts, such as Facebook or Instagram. Our chief medical officer would talk about concerns or misinformation people had. One of the rumors, for example, was the infertility fears that people had from getting the vaccination, and we really worked hard to debunk those myths. We also had opportunities where our staff, such as our chief medical officer, would appear on the local news stations to discuss some of the hesitancy and factual information. And whenever we would make contact with our members and this topic came up, we made sure to direct them to their local health department, the CDC, the NIH, et cetera, for more valid information about COVID and the vaccine.
Thanks for that, Jen. Lauren, why don't I turn to you next?
Thanks, Renee. CCA used the entire interprofessional team, including and highlighting our health outreach workers, to educate members about vaccinations, answer questions, or address anxieties about the vaccinations. Many individuals were anxious or were experiencing severe isolation, so behavioral health specialists worked with folks telephonically around vaccination and other issues related to the pandemic, like social isolation, not being able to see family, friends, or peers. We identified CCA members that were homebound and were able to do at-home vaccinations. In addition, the state of Massachusetts asked us to support them in at-home vaccinations for non-CCA members. We quickly pivoted to that, although this was often challenging to get enough nurses that could disperse from our 4 geographic locations across the state of Massachusetts. Even though these are home visits, it could still be challenging to reach all members in order to use each day's allocation of vaccinations. So we had to be prepared to be able to utilize all of the vaccinations each day, so had emergency lists to accommodate that. Staff at the previously mentioned COVID-19 isolation recovery sites, the hotels, provided education on COVID-19 vaccination and connected participants to community providers who then could support participants in getting the vaccine in the community. At the time, we were unable to give vaccinations at the hotel sites because the limited time the guests were staying with us.
Thanks, Lauren. Tasha, why don't we turn to you to find out how the Community Health Plan of Washington rolled out its vaccination engagement efforts?
Yeah. At the onset of the pandemic, we provided information to members based on available guidance at the time. Once vaccines became available, we assisted members in scheduling appointments and or arranging transportation to vaccination appointments. Over time, our outreach became more targeted to specific populations. One tool that enabled us to be more targeted in our efforts was a dashboard that we created to track vaccination rates by area and provider. We used the tool to identify communities with disparities in vaccination rates, and then we reached out to and collaborated with providers and community partners in the area to serve these populations. We also communicated with members via text in their preferred language to provide information about vaccine efforts or events in their communities. And we also collaborated with our local health department by providing data on members who are unable to leave their homes to ensure they could receive vaccinations through the health department's mobile vaccine efforts.
Thanks, Tasha. You know, as I close out this section, I think it's, of course, worth mentioning that we're speaking about these efforts in the past tense, but I just want to acknowledge, of course, that all 3 of your plans are, I'm sure, using some of these same approaches as you work to get people their boosters. But why don't we shift gears one more time here and talk about a couple of subset populations. As I said earlier, the harder to reach population is quite varied. People are hard to reach for a whole variety of reasons, but 2 subpopulations may be exceptionally hard to reach. And those are people experiencing homelessness or those with serious mental illness. And I wanted to invite each of you to talk about some of the specific examples of strategies that your plans or your affiliated providers employed to engage either one or both of those populations. So why don't we start with you, Tasha, and then we'll go to Jen and then to Lauren.
Thank you, Renee. One of the exacerbated challenges during the pandemic for us was engaging members living with behavioral health conditions, attempting to engage with members in case management services. We really were working to determine the best way to connect with these members. To address this gap of not being able to engage, we leveraged our community health workers to locate these members. Our case managers coordinated with our community health workers. And once a member was located, the community health worker completed a health risk assessment. The health risk assessment helped the case manager develop a plan of care after the warm handoff. We recognize the importance of building trust and being consistent in our relationships with members experiencing homelessness or living with behavioral health conditions. To build trust with our members, we work to address the most critical needs before we discuss behavioral health needs. This helps to show members that we are dependable and consistent. Once we establish an initial relationship with members, our community health workers use a variety of strategies to support members' behavioral health needs. This includes using recovery-oriented and strengths-based person-centered language, using motivational interviewing tools, connecting members to behavioral health providers, and working to help members understand how to use their behavioral health benefits. We also provide education on peer support, helping members understand the value of connecting with another person who lives with a mental health or substance use condition and how that could be helpful in their recovery journey.
Thanks, Tasha. Why don't we turn to Jen?
Viva works closely with hospital staff in the areas and provides support and outreach to our members. And we really work, as I mentioned previously, to foster that relationship with the hospitals, as it's particularly important to the members with serious mental illness. We work and continue to work to make stronger connections with those hospitals and have regular staff meetings prior to the pandemic to really kind of concrete those relationships to make a more successful outreach with members of the group that can be hard to reach. Excuse me. Our VCare team, which are our intensive care managers, contact the hospital discharge staff. They can contact shelters, members, family members, their caregivers, or group home leaders to assist in locating alternative housing options for members with mental illness, as stable housing can be quite an issue. The result of this coordination is very helpful during a transition. We also have that warm handoff where the member is going directly from their discharge planner at the hospital helping them to our staff, seamlessly getting them back into the community. And we hope that this not only decreases the stress of the member having to figure out how to navigate their discharge, because it can be very complicated, but also increase the likelihood of a positive outcome. Our care manager is able to follow the member after for 30, 60, 90 days or longer, depending on the specific situation of the member, to ensure that that is a really solid discharge plan. Members can also contact their care manager, say they aren't necessarily in the hospital, but it's several months down the line and a new issue comes up. They can reach out to them and they can have someone to provide support while they're tackling these new challenges after discharge. Our care managers are excellent advocates and supporters of our members, and we're very proud of them for that. And we really feel that also by having that strong support after, it helps provide a positive accountability for the hospital where they want to make that discharge plan very solid. We connected with members to determine what community organizations they're utilizing, and we make sure that we're passing our information along to these organizations just to better wrap the interdisciplinary care team around the member who may be experiencing that behavioral health challenge, and helps us to eliminate the gaps in their plan of care by doing so. If providers and CBOs in the field have knowledge of the services we're able to provide as a result of our communication and outreach, we hope that they will then share that benefit of our care coordination with the members whenever they come upon the information they may have our plan. We hope that this reduces the chances that the member will fall through those cracks and also increase the capability of the treatment team to work with the CBO on shared goals that they may also have with the member. An example of that would be transportation. It is essential to a variety of aspects for ongoing stability as well as disease management. So our CBOs are informed of our non-emergency transportation benefit with a group called MTA within the Birmingham and full state, and then Ride Health, which is more in the Huntsville area for our SNP members. So we hope that by having that benefit, not only is it benefiting the member to ensure that they have consistent transportation to their appointments, but also preventing the CBO from utilizing what resources they may have, as they may be limited, for the transportation to the appointment.
Great to underscore the importance of transportation, which I know we talked about a lot with respect to the COVID-19 vaccination, getting people to the COVID vaccination sites. So thanks for raising that, Jen. Lauren, why don't we have you close out our discussion on these particular populations?
Thank you. So all of our members at CCA have access to a licensed behavioral health clinician as well as a health outreach worker. Many of our members have barriers to get into facilities, and if they miss appointments, they are not able to return to the facility for 6 to 8 months to get another appointment. So they have access to our own clinicians that are able to provide crisis management, diagnosis and assessment, connect them to resources in the community, and most importantly, be able to do home visits and conventional therapy in their home.
Lauren, did we lose you?
Hear me?
Now we can, yeah.
Okay. All right. So in addition, we have developed a 26-bed crisis stabilization unit that we operate with a partner, a human service provider, to treat members with psychiatric and substance use issues. This allows us to divert members from emergency departments and unnecessary inpatient stays to this unit, which is more of a community-based setting than an institutional setting. In Massachusetts, a typical crisis stay is 3 to 4 days. However, our CCA patients can stay for as long as their needs require, and we can provide additional wraparound services as they transition back into the community. Previously, we saw people go between emergency departments to get treatment for their psychiatric concerns or substance use. Members that were disengaged prior to arriving at the crisis units may become more engaged after accessing these services and learning more about the support the plan can provide. We often connect them to primary care, behavioral health services, or substance use services in the community, as well as their care team in the community. Additionally, we have the behavioral health clinician and recovery coaches on site in the emergency departments who offer face-to-face contact and engagement. This allows us to transition members to our crisis unit or do a warm handoff to our community teams.
Thanks, Lauren. Wow, it sounds like there are a really wide variety of approaches that each of your plans are using across a wide spectrum to reach and engage these two populations. Thanks for that. I think we're going to close out with one last question for everyone. I wanted everybody to look forward a little bit and ask you each to share what you learned about engaging hard-to-reach members as a result of the pandemic, and what strategies you might continue to use moving forward that you may not have been using before. I think everyone talked about getting creative, and so I just wanted you all to reflect on how those strategies might be able to be used in the future. Lauren, why don't we start with you? We'll go to Tasha and then to Jen after that.
Thanks. So at CCA, we had to pivot quickly to virtual care. We initially didn't think members would be receptive to virtual care given their distrust of the system and wanting to see people face-to-face. We were happily surprised that a good percentage of members were receptive and able to utilize telehealth services. For members that have been receptive to virtual care, we will continue a hybrid method, both in person and virtually. This allows for more staffing efficiency in terms of supporting all of our members across the state. We are also thinking about device allocations and Wi-Fi for our members who do not have access to technology. Many members typically still want at least a quarterly in-person visit, but are happy to utilize virtual care. CCA anticipates expanding all of our care and services throughout all of our facilities, including groups, to conduct hybrid care where possible and desired. We are reflecting on lessons learned from our isolation recovery sites and our ability to connect 95% of those folks to resources for longer-term care, even though they were only with us for a short time, 10 to 12 days. CCA did a lot of analysis around food insecurity and saw an increase during the pandemic. We are looking for creative and innovative ways to support members through our engagement center or other organizations to help manage their food access.
Thanks for that, Lauren. Let's go to Tasha.
Thank you. So we plan to continue to grow the role of our community health workers as part of the care team and leveraging our connections to communities to enhance our ability to get members what they need when they need it. Our community health workers reflect the diversity of our membership, and they're well connected within their communities. The foundation of our care approach is locally delivered whole person care, as I mentioned earlier, and our effort to create regional care teams is an integral part of our integrated care approach. We are in the early stages of developing regional care teams, which include staff in various roles, including regional case managers, community health workers, field case managers. We'll also be exploring other roles as a part of the regional care teams as we move forward. But the regional care team staff live in the communities they serve and support the expansion of our in-person services programs for our members. So it goes beyond just the community health worker living in the community, the whole regional care team. The staff on the regional team have relationships with providers and other member-serving organizations and would work together to support members in achieving optimal health outcomes. While this is not new for us, we plan to continue to collaborate with external organizations. That's something that's foundational and core to us. Our extended meal benefit and our partnership with county health departments are great examples of working with others to meet the various needs of our members. We have been spending time working to develop a long-term social determinants of health strategy, which includes partnering and collaborating with a range of stakeholders, government entities, and community-based organizations.
Thanks, Tasha. And Jen, you get the final word on this.
Okay, thank you. One helpful thing I think that really stood out was the streamlining our contact with our members, and it's something that would really positively and does positively impact our member experience. Because telephone contact was that primary resource of communication, we really focused on being mindful of how many times we're reaching out to the member and really collaborating as a team to reduce that fatigue. Our hard-to-reach button, as I've mentioned before, was really supporting of those efforts, and it also lent to us being much more cohesive in our outreaches. Instead of having multiple contacts from the same company to the same member. Similar to that hard-to-reach button, we implemented a COVID-19 vaccine button. It's another hover over, and that was something where we could look at claims, we could gather the information from the member, we could look at information gathered from the PCP or providers to see if that member is partially, fully refusing or hesitant of the COVID vaccine. And we could take that information and put it in that hover button and then show that we can communicate whether that's something we might want to address, whether in the care management, whether with our Connect for Quality, which is our outreach team for preventive care. That was something that we just really wanted to globally make available without having to put a lot of information in a very small spot. We could be very precise and effective with that information.
Well, thank you, Jen, and that was a great way to close us out for our panel discussion. I wanted to thank all of you for this conversation and in particular for your participation in the community practice. It's really been an honor for me, and I know for my colleagues at the Lewin Group, to work and learn with you guys and your peers over the last year, especially since it's been a pretty difficult period of the pandemic. So thank you again, and I'm going to shift now again, and instead of me asking questions, we're going to take questions from our participants. I'm going to turn the program back over to Laurel, who will moderate the section. Laurel?
Thank you, Renee, and thank you, Lauren, Tasha, and Jen for sharing all of your great insights. With that, we do have some time for questions from the audience. And thank you to everyone who's already submitted questions either through the Q&A feature or during registration. But if you do have any additional questions, please submit those now using the Q&A feature in the lower left of the presentation screen. You can type your comment at the bottom of the Q&A box and then press submit to send it. But I'll start out with a few questions that we've received thus far. A lot of participants have asked some questions about how to best support folks living in rural areas where cell phone access may be limited, and some members may only have access to mail on a monthly basis. So Jen, this question's for you. Do you have any recommendations from your experience in reaching rural, hard-to-reach members in particular?
One thing that we have started doing again, which there are face-to-face interactions, and those rural members, they don't have a lot of resources sometimes. So what we can do since July of this year is send our staff out if the member requests it and, we have an assessment for concerns about infection for COVID specifically. But we are, if the member is willing, reintegrating our staff and doing that face-to-face. We also have staff at the primary care offices, depending on that office's particular protocol for COVID. They're called Connect for Quality Nurses, and they're there to get a lot of global information and make sure that the PCP, the member, and us are on the same page about their care. So meeting them at their primary care office could be another option. And I think front porch visits are always a good thing too. You're out in the fresh air, but it also provides that distance.
Great, thank you, Jen. This next question is for Jen and for Lauren as well. Maybe Lauren, we can start with you. Could you speak a little bit about how your plan helps to incorporate member voices in an effort to better understand the needs of hard-to-reach members?
Sure, thanks. So CCA actually has a designated member voice program where we incorporate members who are interested in participating in development and implementation of really all of our programs, including our clinical model. So we'll discuss features of innovative clinical models, and they will, at the beginning of the journey, be giving input, suggestions, to the end of the process and development of the program, where helping us to pick furniture in facilities and appropriate colors for the facilities. In addition to, during the pandemic, as we pivoted to virtual care, they were helping us to test technology that would be appropriate for members and their peers. So we really do incorporate our members who have identified as wanting to participate in helping us to evolve our clinical model, evolve our technology, and be involved in the facilities and programs that we're developing.
Great, thank you, Lauren. Jen, do you have anything to add there based on your experience?
Sure. 2 times a year, we complete a member experience of care survey, and this is to randomly select the members who have been engaged in our V-Care or intensive care management. That's something that we can get a lot of information, what's working in our plan when it comes to our management and that face-to-face interaction or telephonic as well, but also what isn't working. And it's something that we actually review with all of our staff at least once a year, just to let them know kind of the temperature of those interactions. Something else we're considering is a consumer advisory committee in order to incorporate the voices of our members into the overall strategy and decision-making process.
Thanks, Jen. This next question is for Tasha and Lauren. Tasha, we'll start with you. Do you have any best practices or strategies in your experience that have been beneficial in reaching out to caregivers in an effort to engage hard-to-reach populations?
Yes, thank you. So for us, reaching out to the caregiver and sharing with them information, what is available, and highlighting the value of caregiver support services, like how that can support them in being a caregiver, we found that to be helpful. Also, requirement to getting assigned release of information so that we can continue to engage them in the plan of care and future interactions with the member.
Great, thanks, Tasha. And Lauren, I know you mentioned working with members who were unable to leave their home. Do you have any strategies for reaching out and working with caregivers in those situations?
Yeah, sure. So I think obviously with member consent, we really incorporate caregivers into the treatment plan and into the member's treatment. So they really are a part of the care team. So again, with the member's permission, the caregivers are really a part of the care team. We often do a lot of education with the caregivers around treatment interventions, thinking about symptoms. They always have access to the care partners to give information if our member does become symptomatic, whether that is through COVID or other complexities in medical or psychiatric illness, they always have access to our care partners to give that information. In addition, we are very cognizant of caregiver burnout. So we really also try to incorporate different strategies for our caregivers to help them with caregiver burnout.
Great, thank you. This next question is around boosters, which is probably top of mind for a lot of folks right now. Lauren and Jen, can you both talk a little bit about, now that boosters have been approved for everyone over 16, can you say a little bit about what your health plans are doing to reach out to hard-to-reach members and let them know about the availability of boosters and help to support them in that way? Jen, we can start with you.
Well, we incorporate informative discussion with our members about how to get the vaccine, addressing hesitance and encouraging the members to surround themselves as much as possible with others who are also vaccinated, just to protect that chronic illness vulnerability. So I think it's just a lot of encouragement that we do, and encouragement of the member to express their concerns about someone who may or may not be vaccinated being around them or around their inner circle. So I think it's just kind of creating that moment of thought for them where they can kind of think about it and then approach it as they feel comfortable.
Yeah, that's great. Thank you, Jen. Lauren, do you have anything to add there?
No, I think we do very similar things, but much like our initial outreach around vaccinations in general, we really do utilize our health outreach workers who have really good relationships with our members or our care partners to educate, reassure, talk through any anxieties or concerns that they have about the booster, and also give them more, hopefully, understanding of the variants and their anxieties around the illness.
Yeah, that's great, Lauren. One more question for you, Lauren. We had an audience member ask about sort of how CCA has adjusted your approach in meeting members where they are during the pandemic. You had mentioned, previous to the pandemic, engaging members at local Dunkin' Donuts, that kind of thing. Could you talk a little bit about how that strategy has had to shift during the pandemic and kind of how you're meeting members where they are?
Sure. At the beginning of the pandemic, we did have to very quickly shift to virtual care, which again came with its challenges because our members were used to, many of our very high-risk members were used to in-person visits and interventions. So we did have to shift to virtual care. We did have a team, what we identified as a field team of clinicians and health outreach workers that volunteered to continue to go into the community with appropriate PPE, and we really focused on more high-risk folks, but that could be medical complexity or psychiatric complexity. And additionally, our staff was able to conduct multiple phone calls per day to each member to ensure that they had connectivity to their team, and as well as being able for us to do assessments over the phone and get the resources they need. We had significant encounter data in terms of being able to work with people around food access, transportation, pharmacy needs, really good success and outcomes in terms of that connectivity with our folks that are typically very difficult to engage.
That's great. Thank you, Lauren. Our next question is for Tasha. You had mentioned some of the supports that your CHWs provide to members, particularly members who may be living with serious mental illness. An audience member had a question about sort of if you provide any trainings on motivational interviewing, trauma-informed care, and person-centered language for your CHWs and what that kind of looks like.
Yes, thank you. So we have had an external trainer come in and train everyone in care management on motivational interviewing. And some of us are also clinicians. Our CHW team is a team of non-clinicians. But some of us who are clinicians have also been trained or have had training prior to that, like through continuing education. So we leverage the training for the whole staff. But one of the things that we do specifically with our community health workers, we regularly engage them in conversations and scenarios regarding using motivational interviewing tools so that we can kind of check for use and experience and ensuring the staff are comfortable using those methods. For trauma-informed care, all of our work is trauma-informed. All of our work with members across teams within our care management department, we're always thinking about, what happened to you, right? Like that's the foundation of trauma-informed care. And again, through our teams, we have regular trainings and auditing processes to ensure that when we're engaging with members, like through our documentation and phone calls, that teams are operating within the context of our care. And for person-centered language, similarly, we do have regular trainings, kind of refresher trainings, practice scenarios, so sometimes it's role play. So I would say it's a combination between those, just making sure that there's regular engagement, making sure that we're reviewing, kind of checking and rechecking for competency, practicing, and making sure that folks are able to apply and utilize the skills.
Great. Thank you, Tasha. Lauren and Jen, this next question is for you. You both talked a bit about coordinating with hospital systems and kind of placing staff in hospitals to help engage hard-to-reach members. Can you talk a little bit about how you managed those relationships during the pandemic, and particularly kind of maybe how those had to shift in light of surges in hospitals related to COVID cases? Jen, we can start with you.
Sure. Well, there was actually a surge shortly after we had returned to the field in July, and everybody was sent home from the office. Everyone was back to that more telephonic styled outreach. So that's something that we just kind of go with the ebbs and flows of what the protocols may be. And then once the numbers came back down, we started incorporating everyone that we could back into the field. But of course, we just continually assure the hospitals that we are here to assist them, because that working relationship is really what makes not only the hospital successful in their readmission aspects, but also our members successful in their health and the outcomes of their health. So we just kind of reverted back to that telephonic security email communication with the discharge planners and maintained what relationships we had already established prior to COVID.
Thanks, Jen. Lauren, how about you? Do you have anything to add here based on your experience in working with those systems?
Sure. So for our hospital to home program, our doctors, our CCA doctors, are actually credentialed at the hospital. So in fact, they were able to continue to work in the hospitals throughout the pandemic in person. However, our health outreach workers and behavioral health clinicians did not have access to the hospital. They have very good relationships with the care management department as well as the emergency department. So as our patients entered, they were called or contacted to evaluate, assess, or they may know the patient, and so we're able to do virtual consults over the phone in combination with the care management departments at the hospitals or the ED or our CCA doctor who was able to go in person. I will say that came with challenges. So for our members who are so complex in going into the emergency department, having that face-to-face visit with a behavioral health clinician or a health outreach worker to determine their needs, their social determinant needs, their behavioral health needs, was really important, particularly when they were in perhaps acute crisis psychiatrically or anxious, nervous about going into the emergency department for medical symptoms. So although we were able to pivot and manage throughout the pandemic with both a hybrid, our doctors in person and our other staff virtually, it did come with its challenges. We also have a transitions of care program that generally our nurses are in the hospitals. That had to shift completely to virtual. They did not have access to hospitals. So that was virtual care working with the inpatient units as well as the social work teams and care management teams at the hospital.
That's wonderful. Thank you for all of that detail, Lauren. That's really helpful. One more question for you, Lauren. You had mentioned in your presentation, that a lot of the members that you serve, have mistrust in the healthcare system, just based on their prior experiences. In your experience, do you have a sense for sort of what types of information have been helpful to share with members, you know, in terms of gaining their trust and making them feel like the healthcare system is set up for them. Do you have any types of information that it seems like they need the most?
Yeah, thank you. I think so many of our members have experienced trauma in their past and are often re-traumatized when in some systems of care, obviously never intentionally, but when they are getting their needs met, they may sometimes feel not believed, or that they're med seeking, or that they're not heard when they're looking for care. And so oftentimes that is re-traumatizing for them. I would say from our perspective, as I mentioned in the presentation, that trusting longitudinal relationship is so important for our members. And I think what we do is obviously always treating people with trust, with respect, thinking about dignity of choice, dignity of risk. It's really important to add immediate value to what their needs are and be reliable and predictable in that. And so if they're having a behavioral health crisis or medical issues, but they say, I'm hungry, helping them to get access to that food immediately, and then supporting all of their other needs. So I think it's that immediate value that we can add to start building that trust, and then being reliable and predictable in their lives and continue to support them in a non-judgmental way.
Thank you, Lauren. Those are great points. I appreciate your perspective on that. I think that's about all we have time for in terms of our Q&A session. Thank you for everyone who submitted questions. There's a lot of great ones in the chat. But if you do have any additional questions or comments, please email ric@lewin.com. Additionally, the slides for today's presentation, a recording and a transcript will be available at the Resources for Integrated Care website shortly. And thank you again so much for joining us today. If you are able, please complete the brief evaluation of our webinar so that we can continue to deliver high quality presentations. And again, if you have any questions for us or the speakers today, please email us at ric@lewin.com and follow us on Twitter for more detail at integrate_care. And again, big thank you to all of our speakers and to the audience, and thank you so much for your participation today.